Hello and welcome. It's been a while. We're back here with a chest case. Today's case is mainly dedicated for juniors, but I think it's also a good case to revise some concepts for seniors as well. And to balance the content, I promised that the next case would be more targeted towards seniors. Now, this is a 17-year-old male patient who was previously healthy and presented with persistent chest pain. You had the chance to look at his frontal radiograph. Let's look at the lateral chest x-ray for a while. Before we dig further into this case, let's go to a normal chest radiograph to clarify some concepts. This is an example of a normal chest x-ray. Let's clarify a few things that are related to the cardiomediastinal border on the left. Of course, to start with, the mediastinum should not be wide. You should not have any abnormal bulges that are not expected in the contour. So what's normal? This is your right side, this is your left side. The first thing we'll start with is this border here, which is the left subclavian artery. The second border is the border of the aortic arch. Next, you see the hilum. To be more specific, this border here is the border of the pulmonary artery. That's why this dip here, the space here, this is called the aortopulmonary window. If you go lower down, immediately below the hilum, you're supposed to have the left atrial appendage living there, but there's a catch here. Books tell us that this is the area of the left atrial appendage. If it is, it's a small part and it's very difficult to see unless the atrial appendage is dilated. For practical purposes, let's look at this larger border here, which is part of the cardiac border. In particular, this is the left ventricular border. Now let's go to the lateral chest radiograph. What we're going to try to identify here is how to differentiate anterior from middle from posterior mediastinal compartments. This is a confusing part for many people who start reading about this because it's written in different ways in different textbooks. A big reason for that is that there are several radiographic classifications. Another reason is that the radiological literature is different in the way it classifies those compared to the surgical literature. I'll give you a simple approach that I like to use, but you're free to read about the others in textbooks. This is your sternum. This dark space here is the retrosternal space. The white opacity here is the heart as expected. There is superimposition of the hilar structures from both right and left side in this area here. This dark column of air is air contained within the trachea, so this is the trachea. The arching white structure here is the aortic arch, and this here is the spine as expected as well. Similar to the dark space, the retrosternal space, here you have another dark space behind the heart, which is the retrocardiac space. One small neat piece of information is this linear structure that you see here. And this white border here represents the border of the inferior vena cava as it ascends from the abdomen to the heart. So knowing that, how do we divide the mediastinum into the anterior, middle, and posterior components? The anterior mediastinum could be considered anything anterior to the anterior border of the trachea, the posterior border of the heart, and the posterior border of the IVC. The middle mediastinum is anything behind that line all the way to a line drawn 1 centimeter posterior to the anterior cortex of the vertebral bodies. And of course, anything behind this line here is considered posterior mediastinum. As you have noticed, these are all imaginary lines. They do not delineate real anatomical boundaries between these compartments within the chest. You have to also keep in mind that pathology in one compartment could overlap with another. For example, anterior mediastinal lesion extending to the middle mediastinum. Now let's go back to the abnormal case and try to apply some of the concepts that we just talked about. Starting with the frontal chest radiograph, you have this large opacity that actually widens the mediastinum. The mediastinum should not be this wide. Now, although this might lead you to think that this is a consolidation within the lung, the fact that you see lung markings through it and the fact that it extends on the other side makes this very unusual for pneumonia or other forms of consolidation. So you have to think about a mediastinal-based lesion. Now, if you decided that this is a mediastinal abnormality from the frontal image, you should think about whether you put it in the anterior, middle, or posterior mediastinum. There are a few hints to the location of this abnormality on this frontal chest radiograph. The first hint is that of absence of the aortic arch, and as we know, the aortic arch is part of the more anterior compartments. Along the same lines, you cannot see the border of the pulmonary artery very well, and the aortopulmonary window is obliterated, of course. Now, the fact that you have Hilar vessels seen through this lesion is important. This tells you that the hilum, which is middle mediastinal in location, is not involved, so the lesion is either anterior or posterior compartment. Furthermore, the left ventricular border that we discussed before is partially absent. And since part of the left ventricular border is absent, you know that this is a lesion that is touching the cardiac border. And you know that since it's doing that, it's located anteriorly, close to the heart. Now, before we go to the lateral projection, the sign of seeing the vessels going through a mediastinal abnormality is called the Hilar overlay sign. And here's the lateral chest radiograph confirming what you thought about just by looking at the frontal X-ray. So this is a large, wide opacity representing the mediastinal lesion that obscures what should be a dark retrosternal space. It's white here. And the abnormality projects over the heart in front of that line that goes anterior trachea, posterior heart, and posterior IVC. By that, you confirm the anterior mediastinal location of this lesion, and now you could generate a reasonable differential diagnosis. The differential diagnosis for anterior mediastinal lesions could be simplified by remembering the rule of 4T. The first T stands for thyroid lesion that extends from above going into the chest. The second T stands for a thymic lesion, including thymoma, thymic hyperplasia, and other thymic abnormalities. The third T stands for teratoma and other germ cell tumors. And the final T stands for terrible lymphoma or T-cell lymphoma. So thyroid, thymic, teratoma, and terrible lymphoma. Of course, those are the common differential diagnostic considerations, but you have lots of other entities that could exist in this location. The fact that you don't have a thyroid abnormality and the patient is young, you have to consider either lymphoma or teratoma. And for radiology residents and seniors, this is the large heterogeneous anterior mediastinal abnormality, clearly seen on this intravenous contrast enhanced study. And the areas that are dark are representative of necrosis. Knowing that this is the ascending aorta becoming the aortic arch. You could see why the aortic arch was not seen on the chest radiograph. The lesion touches the aortic arch. The lesion is also in contact with the left cardiac border, and that's why part of the left cardiac border was not observed on the abnormal chest radiograph. The abnormality fills the space here, which is supposed to be a relatively clear and clean retrosternal space. And this large mass compresses the structures posteriorly, such as this compressed pulmonary artery. Further discussion of the CT findings is beyond what I want to discuss today, but of course you have to assess invasion of structures such as vessels and airways. The same for T differential stands true, and given the heterogeneity and the absence of lymph nodes, a germ cell tumor was favored. Since there is no clear cystic component, fat, or calcium, a mixed germ cell tumor or malignant teratoma were favored. This turned out to be a proven mixed germ cell tumor, so it had multiple components. So let's end the case by revising what we learned today. Knowing your mediastinal contours may help you identify if the lesion is in the anterior, middle, or posterior compartment from the frontal radiograph. The contour on the left is represented by the left subclavian artery, aortic arch, aortopulmonary window, pulmonary artery, and left ventricle. If you see the Hilar vessels clearly through a mediastinal lesion, that means that this abnormality is either very anterior or posterior, presenting the Hilar overlay sign. We learned how to divide the mediastinum into anterior, middle, and posterior compartments on the lateral chest X-ray. We learned that there are variations in the literature. We also learned about this neat structure here that you could see on most chest X-rays, which is the IVC. Finally, once you decide that the lesion is in a specific compartment, you could derive a differential diagnosis. If it's in the anterior compartment, you could use the 4T rule. And with this, we end the clip. Thanks for watching. Your comments and interactions are more than appreciated, and see you with more cases later. Hello everyone, this is a case that's dedicated for radiology residents and seniors. Neurology and neurosurgery residents might find this useful as well. I'll try to explain a few things to make it more plausible for juniors. This is a 45-year-old female who presented with recurrent seizures. Here's another look. The abnormality is obviously centered on the temporal lobe on the left. The lesion also extends all the way up to involve the insula and the external capsule. Since the fluid, the CSF, is bright, this is a T2 weighted image. As we learned from previous clips, on normal T2, the gray matter of the cortex is white and the white matter, which is deep here, is gray. So the color of normal tissue is the opposite of what you expect on a T2 weighted image. Comparing both left and right temporal lobes, you'll notice that the left temporal lobe is involved by this bright, hyper-intense, large area of abnormality. You could tell that the lesion exerts mass effect since you don't see any sulci containing CSF here, where on the opposite side you see them clearly. To better appreciate the abnormality, we will suppress the CSF fluid. As you see, the CSF here is dark. And this is still a T2 weighted image. As you could tell, the gray matter is white, the white matter is gray. The only difference is that the CSF is black and suppressed. By suppressing the CSF, it's much easier to appreciate the white matter hyperintense abnormalities here. This sequence where CSF is suppressed on T2 is called FLAIR. Now, as we mentioned before, the lesion is involving the temporal lobe. It exerts mass effect by effacement of the sulci and the CSF spaces. Now, before we proceed, let's stop here for a moment and think about the major differential diagnostic possibilities. The three big categories to consider here would be stroke, infection, or neoplasm. If this lesion were to be stroke or infection, the presentation would be different and would be likely acute. Given that the patient presented with long-standing recurrent seizures, this makes stroke and infection less likely. Although the cortex appears thickened here and you have an L-defined border between the gray and white matter, this also does not fit with acute stroke, since you lose the cortex if this were to be cytotoxic edema from stroke. An infection that likes the medial aspect of the temporal lobe is herpes encephalitis. However, the presentation would be acute, as we mentioned, and that's typically a bilateral asymmetric process. The right side is normal here. The fourth consideration, which is less likely, is that of seizures, since status epilepticus may have some features on MR. With status epilepticus, the abnormality is mainly centered on the cortex, and it could have some subcortical involvement, but this large area of involvement goes against that. Add to that that mass effect is less likely with status epilepticus. So with all this in mind, the most likely consideration here would be a neoplastic process. Now let's proceed by looking at this T1 weighted image after giving IV contrast. We know that fluid is dark on T1, so the CSF within the ventricles is black here. And we know that T1 weighted imaging is the most anatomical image, where gray matter is gray and white matter is white. So looking at the colors of the gray and white matter would help you differentiate a T1 from a FLAIR sequence. Now this is T1 with contrast. I'll give you a chance to look at this. After giving contrast, most of the lesion does not enhance. There's only these areas of patchy L-defined mild enhancement. So stroke would not classically enhance unless it's subacute, where the enhancement is different in appearance. It's a gyriform enhancement typically. In case of an infection, cerebritis, you might have various patterns of enhancement. If the infection reaches a stage of an abscess, the enhancement would be more rounded and more confined. Herpes encephalitis, as we mentioned before, is a form of infection that is bilateral, where you may have mild enhancement as well. In case of the less likely possibility of status epilepticus, you would not expect enhancement. Now, does the lack of major enhancement go against a neoplasm? And the answer is no. If you're suspecting a neoplasm, it depends on the grade of the neoplastic tissue. Primary brain tumors, known as astrocytoma, could be very low grade or could be high grade. Despite that, astrocytomas could be very infiltrative. If they're low grade, they do not enhance. The higher grade of astrocytoma, known as anaplastic astrocytoma, could show areas of enhancement. And the worst grade of astrocytoma, known as glioblastoma, would typically show more intense foci of enhancement. So what we're looking here is compatible with a low-grade diffuse astrocytoma. And the small foci of enhancement here would suggest a high grade, whether in the form of anaplasia or focal glioblastoma. So this is an important piece of information. Enhancement decides the grade for you, but the extent of the lesion should be assessed on T2 or FLAIR. Again, do not depend on the post-intravenous contrast enhancement acquisition to decide on the extent of the tumor. Enhancement helps with the grade, T2 and FLAIR helps with the extent of the lesion. This lesion was resected and the diagnosis was a diffuse low-grade astrocytoma with foci of anaplasia. So let's recall what we talked about today. First, for juniors, we differentiated between T2, FLAIR, and T1. Whether CSF fluid is suppressed or not, on T2, gray matter is white and white matter is gray. It's opposite on T1. Large areas of high signal intensity on T2 could represent stroke, infection, or neoplasm. The presentation with stroke and infection would be more acute, while it's very different when it comes to neoplasms. We mentioned a few imaging differentiating points between these categories, and we talked a little bit about status epilepticus. This is also a very good case to show you a few features of diffuse low-grade astrocytomas in the form of a large area of high T2 signal intensity, L definition of the gray-white matter junction, and thickening of the cortex. We emphasize the point of looking for extent on T2 weighted imaging and FLAIR, and for utilizing T1 with contrast to assess areas of enhancement that denote the grade of the tumor. Low-grade astrocytoma does not enhance. Anaplastic astrocytoma shows mild to moderate enhancement. And the highest grade, known as glioblastoma, would show intense enhancement. By that, we end today's case. Thanks for watching. Your comments and interaction is more than appreciated, and see you with more cases later.